Hello, today we're going to be talking about the endocrine system and some of the way it basically works, as well as some of the disorders of the endocrine system. Here are the objectives for the day. Again, more objectives and understanding and defining all the dysfunctions of the endocrine system. Let's talk about the endocrine system in general. We know that the endocrine system is the messenger for the nervous system. So the endocrine system and the nervous system together are the two primary communicating systems in the body. The endocrine system uses hormones to communicate, and then those hormones exert some kind of an effect on the target tissues. Let's talk about a negative feedback loop. This is the way it works. So the hypothalamus will release a hormone, a chemical messenger, that goes to the pituitary, and the pituitary senses that messenger and will release another hormone. And that hormone will travel and send a message to a gland, like the thyroid gland or the adrenal gland. And then the thyroid gland or the adrenal gland will release their hormone. And those hormones will have an effect on the cells of the body. When those hormones are low, there's not enough circulating hormone, a message goes back to the hypothalamus that says, send out another message, start up this whole process. So the hypothalamus will send a message to the pituitary, which will send a message to the gland and will produce more hormone. When the hormones are high or circulating in sufficient quantity, there is no message back to the hypothalamus, so the hypothalamus is quiet. Then when the hormone drops low, the hypothalamus gets a message that says, send a message to the pituitary sends it to the gland, and the gland makes the hormone. That is a negative feedback loop, and we'll look at it specifically in the different disorders. We're going to start talking about the thyroid gland. What do we know about the thyroid gland? Well, we know it's in your neck. We know it's got two lobes connected by a narrow piece of tissue they call the isthmus. We know it's extremely vascular. As a bit of trivia, about 5 times more blood passes through the thyroid than the liver. We know it secretes thyroid hormone T3, T4, and calcitonin. Let's talk about the specific negative feedback loop for the thyroid. We're talking about HPT, hypothalamus, pituitary, thyroid gland. The hypothalamus, when thyroid hormone is low, the hypothalamus will release TRH. TRH travels in the blood, gets to the anterior pituitary, sends the message to release thyroid stimulating hormone. Thyroid stimulating hormone travels in the blood to the thyroid gland. With the help of a little bit of iodine, the thyroid gland produces T3 and T4. When T3 and T4 are in sufficient quantities, when there's plenty of the T3 and T4 to exert their effects on the cells, there's no message back to the hypothalamus. When T3 and T4 levels drop, a message goes back to the hypothalamus. The hypothalamus releases the TRH, sends that to the anterior pituitary. The pituitary releases TSH. TSH gets to the thyroid gland, and the thyroid gland releases T3 and T4. Let's talk about those thyroid hormones. Nearly all T3 and T4 is bound to a serum protein, and it can't enter a cell. So that's to say that nearly all T3 and T4 that is produced is no good for the cells of the body. It's not available for them to use. most of what is secreted is T4. 90% of T4 is excreted from the thyroid gland. T3 is the more physiologically active hormone. That's the one that has the most effect on the cells. So T4 is converted to T3, and then T3 exerts its effect on the cells. Just to note that the body needs 1 milligram of iodine each week in order to help produce thyroid hormone. So in countries where there is no thyroid hormone, or when there is no iodized salt, sometimes they have a hypothyroidism related to a lack of iodine. What does thyroid hormone do? What's effect does it have on the body? Well, it controls metabolism. And by metabolism, I mean everything that your body does, the work that the cells do. It controls the speed. So it controls metabolism. It controls caloric requirements. It controls oxygen consumption. It controls carbohydrate and lipid metabolism, growth and development, brain function. And how does it do that? One of the primary ways that it does that is thyroid hormone changes the cell sensitivity to the catecholamines. Wow, that was a lot to say. The thyroid hormone changes how sensitive the cells are to the catecholamines. We remember that the catecholamines are the neurotransmitters, the chemical transmitters for the sympathetic nervous system. Well, we've studied the sympathetic nervous system a whole lot, and we know that the sympathetic nervous system has a lot to do with increasing heart rate, increasing blood pressure, increasing contractility, increasing cardiac output, increasing respirations. It has a lot to do with the liver releasing sugar. It has to do with cell sensitivity and insulin resistance. So if I have a hormone, a thyroid hormone, that changes the sensitivity of a cell, and I have too much hormone, you can see that everything will be going super, super fast. If I have too little thyroid hormone, you can see that everything will be slowed down. Let's talk about hypothyroidism. It is an insufficient circulating volume of thyroid hormone. It's fairly common. So that is to say, it is hypofunction of the thyroid gland, which results in a decrease in circulating thyroid hormone. What causes it? Well, let me do this slide. It's one of the most common disorders in the United States. It affects more women than men, and it is decreased circulating thyroid hormone. It can be primary, secondary, or tertiary. Primary meaning you have a problem with the thyroid gland itself. Secondary meaning that you have a problem with the pituitary. And tertiary meaning you have some sort of a problem with the hypothalamus. Doesn't matter whether your cause is primary, secondary, or tertiary. The clinical manifestations are exactly the same. What causes hypothyroidism? Well, most often it is an autoimmune problem. It is a thyroiditis. They call it Hashimoto's thyroiditis. So somehow the body, we have talked about the autoimmune disorders. So when you see autoimmune, you know that the body is attacking its own tissues. So the body is attacking the thyroid gland, and when the body attacks the thyroid gland, it destroys it, and it's not able to make the thyroid hormone that it's supposed to, and the person has thyroiditis. It can also be as a result of treatment from hyperthyroidism. Sometimes people have hyperthyroidism. We give them medication, which we're going to talk about, to ablate or to slow down or to kill portion of the thyroid gland, and the end result is hypothyroidism. And lastly, we have the culprit, amiodarone and lithium, have an anti-thyroid properties and can also cause hypothyroidism. And we can't rule out the surgical removal of the gland, especially if that was because of hyperthyroidism. I just want to mention that we can do tests to identify if it's an autoimmune thyroiditis because the person will have T4 antibodies. Okay, hypothyroidism, what are the signs and symptoms? Well, initially they're pretty nonspecific, but then they'll generally gradually increase with time. So it is hypothyroidism. We know that is going to be slowing down. It is going to be everything going much slower because there's less sensitivity to the catecholamines because the thyroid hormone controls metabolism. So what are we going to see? We're going to see fatigue, lethargy, bradycardia. We're going to see thin, dry skin and hair, brittle nails. We're going to see constipation. We're going to have perhaps weight gain, a cold intolerance. We're going to go through each one of the systems. But so everything is slowed down. When I say hypothyroidism, you think about every system going slower. Every system going slower, cardiovascular system. So you think decreased cardiac output, decreased contractility. You think increase in serum cholesterol and triglycerides because that's because of liver function. You think that they're short of breath on exertion. You think that there's a low exercise tolerance. Fatigue, lethargy, mood changes, slow mentation, slowed speech, even somnolence. We talk about decreased GI motility, which leads to constipation. There we have the hair loss, dry, coarse skin, brittle nails, muscle weakness and swelling, weight gain. There's something that we call mixed edema coma. So if hypothyroidism is everything slowing down, there's a condition that is a severe problem where everything is slowed down so much, we call that mixed edema coma. What does it come from? It comes from undertreated or undiagnosed hypothyroidism. It results, and it looks just like hyperthyroidism. It is a medical emergency. It's a medical emergency because there is severe bradycardia, severe hypothermia. We're talking about down to 91, 95 degrees, and a decrease in the deep tendon reflexes. Respiratory acidosis, because they are breathing so slowly, they're holding on to the CO2. A decrease in level of consciousness, which can progress to a coma. Hypoglycemia. So these are very, very significant findings. It is hypothyroidism. It's just taken to a whole new level. Like I said, it is a medical emergency. We need to put these people on a cardiac monitor. Sometimes they even need ventilatory support. They need IV Synthroid, which is thyroid hormone replacement. And important to remember is that all meds need to go IV because we're concerned about a paralytic ileus. and we question the GI absorption of meds. So that's something important to remember. So we have hypothyroidism, which is the slowing down of all the body systems. And when we have an increase in those symptoms because they are undiagnosed or undertreated or untreated, we can move to mixed edema coma, which is everything completely slowed down: heart rate, blood pressure, contractility of the heart, hypothermia, breathing is slowed. And for those reasons, you'll see that there's tissue hypoxia, because we said there's decreased cardiac output. So there's tissue hypoxia, altered tissue perfusion. There's bradycardia. There's the hypothermia. So IV Synthroid, all meds go IV because of the paralytic ileus, and we're questioning GI absorption, and we're going to put them on a cardiac monitor and support them with a vent if necessary until it's resolved. Important to note about mixed edema coma. We said it comes from untreated or undertreated or undiagnosed hypothyroidism. It can also be precipitated by an acute illness, or by stopping your meds suddenly, or by the exposure to extreme cold or trauma. Anesthesia. So your hypothyroid patients, we are concerned when we are using sedatives or anesthesia that we might precipitate this mixed edema. And again, you remember the important parts to the important takeaway from mixed edema coma is that we are going to maintain the airway and have ventilatory support, IV Synthroid, IV antibiotic medications, and support all the vital organs until we are able to get the person back to a euthyroid state. Hypothyroidism, diagnostic studies. All right, so we need a good history and physical. We want to hear, is the hair falling out? Is your skin dry? What's going on? We want to know all those things. We want to talk about how the person's feeling. So good history and physical. Then we're looking at TSH, serum TSH. If TSH is high, so certainly we're looking at the thyroid hormone, but TSH is very important to us, because if TSH is high and thyroid hormone is low, we know that there's a hypothyroidism. Because when we think about that negative feedback loop, what we have is we have the hypothalamus sending a message to the pituitary gland, and the pituitary is releasing TSH, and it keeps releasing more and more and more TSH because the message keeps going back to the hypothalamus. It's saying we don't have enough thyroid hormone. So the hypothalamus and the pituitary are releasing and saying, come on thyroid gland, go ahead make that thyroid hormone, but it's not there, and so the TSH will be high with hypothyroidism. We also look at T3 and T4, and it's important to look at those, but it's really important to look at free T4. Why is it important to look at free T4? Because we said that T3 and T4 are highly serum bound, and when they're serum bound, then they're not available to exert their effect on the cells. And we know that 90% of what is secreted is T4. And that T4 is converted to T3. So if we look at the unbound T4, the T4 that's available to convert to T3, that's what we have available to exert its effects on the cell. We're also going to take a look at the presence of T4 antibodies, which indicates that T4 is being destroyed by the body. Okay, so we said you could have a Hashimoto's thyroiditis, which is an autoimmune problem that attacks the thyroid gland itself. You can also have an autoimmune hypothyroidism because your body is actually attacking. It decided that it doesn't like the T4. So we find the presence of T4 antibodies. So we would definitely want to do that antibody test. Collaborative care. What are we going to do to take care of these people? Well, some of what we're going to do to take care of these people is to medicate them. We want to get them back to what they call a euthyroid state. That means where the thyroid hormone, there's enough circulating thyroid hormone. So what do? Well, we make a diagnosis. The TSH is probably high. The T3 and T4, particularly free T4, is low. Maybe there's a presence of a thyroid antibody. And so we're going to give them thyroid hormone replacement. The most common thyroid hormone replacement is levothyroxine or Synthroid. What do we teach these people about the thyroid hormone? You need to take it the same time every day, first thing in the morning, a half hour before you take any of your other meds or eat. You can't skip it. What do we need to know about the thyroid hormone, especially when they first begin the thyroid hormone? We want the person we're teaching report any chest pain or any feeling of palpitations, or we're looking for cardiac dysrhythmias. Why are we looking for angina and cardiac dysrhythmias? Well, we know the thyroid hormone controls the cells, the metabolism of the cells, the sensitivity to the catecholamines. So if I give thyroid hormone replacement and I give too much, I got the dose wrong, then I have a lot of circulating hormone. Then I'm going to have everything speeded up, increased heart rate, increased blood pressure, and therefore I am at risk for angina and cardiac dysrhythmias. What other things are we going to teach them? Well, we have to support, especially until we get the thyroid situated, we want to support a low-calorie diet because weight gain is a significant possibility because their metabolism is so slow. We want to talk about a bowel regimen because GI motility is down. So until we get the thyroid to a euthyroid state, we want to talk about good bowel habits like increasing activity, increasing fluid intake, and increasing fiber. Okay, let's shift gears a little bit, and we're going to talk about hyperthyroidism. What is hyperthyroidism? By definition, a sustained increase in the synthesis and release of thyroid hormone by the thyroid gland. In other words, too much thyroid hormone. It is much more prevalent in women than in men, and it usually hits people 20 to 40 years old. The most common form of hyperthyroidism is called Graves' disease. It is thought to be an autoimmune problem, which we're going to talk about in a minute, and other causes. You could have a TSH secreting tumor on the pituitary gland. You could have thyroid cancer, nodules that are secreting this TSH. And so we talk about that negative feedback loop that we talked about for the thyroid. And so what happens is in hyperthyroidism, we have that hyperactivity of the thyroid. So we have a sustained increase in thyroid hormone. It's usually precipitated. Let's talk. I'm going to flip this slide and then talk about the Graves' disease. Okay, the Graves' disease. It's an autoimmune disease of unknown etiology. That means we don't really know why the immune system is triggered, but it is. There is some sort of a genetic predisposition. That we're sure of. Some sort of a genetic predisposition that is, and it is triggered, like all autoimmune diseases, it is triggered by some sort of a precipitating event. like an extreme infection or a very stressful life event, the death of a spouse or a child, something along a bad diagnosis for someone. So the genetic predisposition with a something that triggers it. The precipitating factors, about 75% of the cases of hyperthyroidism are Graves' disease. So somehow this autoimmune problem, somehow the patient develops antibodies to the TSH receptors. And these antibodies to the TSH receptors, which they attach to the receptors, and they stimulate the release of T3 and T4. So what happens is somehow the body is attacking, is making these antibodies. These antibodies are making their way to the thyroid gland. And the thyroid gland thinks it's TSH. It thinks it's receiving a message from TSH. And so they're releasing T3 and T4 in excessive quantities. And those excessive quantities can lead to thyrotoxicosis. And it eventually might lead to it might burn out the gland. And so lots of times people who had Graves' disease, who had a hyperactive thyroid, based on the treatment that we do, as well as the overactivity of the gland, eventually lots of times they end up with hypothyroidism, which is kind of a little hard to get a hold of right now in your mind. But just know that Graves' disease is an autoimmune problem that is common, results in a decrease or an increase in circulating thyroid hormone. It has to do with TSA, thyroid stimulating antibodies. Those thyroid stimulating antibodies make their way to the thyroid gland, and they stimulate the thyroid. The thyroid thinks that they're supposed to be making T3 and T4, and the amount of T3 and T4 is very high. Graves' disease is often associated with a goiter, as well as exophthalmos, which we're going to talk about and see a picture of in a minute. Clinical manifestations. How do I know somebody has this excessive thyroid hormone? Hypothyroidism slows everything down. Hyperthyroidism speeds everything up. So metabolism is up. Tissue sensitivity to the catecholamines is up. So that means heart rate's up, blood pressure's up, contractility's up, oxygen consumption's up, GI motility's up. And we developed this condition called exophthalmos. The eyes become bulging, and the eyeballs stick out of the socket. The reason for it is there's an impaired drainage, and they get all this retroorbital fat and edema in there. But 20 to 40% of the patients who have hyperthyroidism, Graves' disease, have this exophthalmos. And it's really important for us to take care of it properly. Here's a picture. You can see how her eyes are big and bulging. So taking eye care is extremely important. Using eye drops to keep the eyes moist because we don't want ulcers. In a patient who's unable to take care of themselves and maybe in the hospital with thyrotoxicosis, which is a complication which we'll talk about in a minute, we might even use tape to keep the eyes closed. So sunglasses outside, eye drops are very important. Some of the clinical manifestations that we might see. We might hear a bruit over the thyroid because everything's going fast and we know it's a very vascular organ. We would expect hypertension because we would expect to have vasoconstriction because that's the sympathetic nervous response. Cardiac output is going to be increased because contractility and heart rate are up. Because of those things, we have dysrhythmias. If it lasts for a long time, the person has hypertrophy, maybe even AFib. When we talked about hypothyroidism, we talked about bowel prep, because of slow GI motility. In hyperthyroidism, we have increased GI motility. They are losing weight. They are eating like crazy. They're thirsty. They're losing weight. They have diarrhea. And when I say diarrhea, they might be going multiple times a day. And when I say diarrhea such that they're going multiple times a day, you're thinking, oh, wow, there's going to be electrolyte disturbances and some acidosis type of some acidosis problem, metabolic acidosis problem. Their skin will be diaphoretic. They will have maybe clubbing of the fingers because of the oxygen, the increased oxygen demand and the lack of it. Hair loss, brittle nails, that's fairly common. There will be fatigue and muscle weakness and maybe even some dependent edema. Everything is going really fast. Fine tremors, insomnia, everything's going fast. It's tough to lay down and go to sleep. Hyperreflexia. Heat intolerance. An increased sensitivity to stimulant drugs, of course. Increase in their base temperature, of course. Let's talk about thyroid storm and thyrotoxicosis. Just like hypothyroidism, a severe medical emergency hypothyroidism called myxedema, there is a severe medical emergency of hyperthyroidism, too much thyroid hormone, that we call thyroid storm or thyrotoxic crisis. It is a life-threatening emergency and treatment needs to be started immediately. What's it come from? From a presumed stressor of some sort, somebody who has hyperthyroidism and there's some sort of an infection, trauma, or surgery. It is life-threatening because the person has uncontrolled hypertension, hyperthermia, sometimes greater than 105, severe tachycardia, agitation, diarrhea is prevalent. The primary concern is to maintain the airway and maintain tissue oxygenation. Heart failure and shock can result. Seizure, again, a medical emergency. What are we going to do? We are going to give PTU and Tapazole drugs. PTU blocks the conversion of T4 to T3. We know the T3 is what has the effect on the cells. So we give PTU to block the conversion of T4 to T3. And we give Tapazole for the same reason. But they take a couple of weeks to work. So they're going to need support in the meantime. In addition to PTU and Tapazole, we're going to give Inderol. And you'll remember Inderol to be a non-selective beta blocker. And what we're trying to do is decrease the excess and inhibit the sympathetic stimulation. So all these, the increased sensitivity to the catecholamines, we're going to try and slow down or block the sympathetic response. We may also give lithium and corticosteroids to decrease thyroid function. Fluid replacement is a major concern because of the increase in the diaphoresis and the diarrhea. So we might also use plasmapheresis or dialysis for these patients. Let's talk about hyperthyroidism and signs and symptoms, diagnostic studies. Okay, well, the diagnostic study or the a good history and physical is very important. We want to have the eye exam. very important. Taking a look at for exophthalmos, which we talked about. We are going to do radioactive iodine uptake. The radioactive iodine uptake is done to differentiate Graves' disease from other forms of thyroiditis. Normally, when you give this, they give you a radioactive isotope. The thyroid will absorb very little of that if the thyroid is normal or if it's another type of thyroiditis. But if it's Graves' disease, if it's a goiter, it will absorb a great deal of that. I think the number is a normal thyroid gland only absorbs up 2 to 4%, and if the thyroid has Graves' disease, up to about 80 to 90% of that radioactive isotope is absorbed by the thyroid gland. So that's a diagnostic procedure. Okay, let's talk about the diagnostic studies. TSH. TSH could actually be normal or slightly low in somebody with hyperthyroidism. If the problem is coming from the pituitary, TSH will be low. And TSH would be low because the pituitary is not doing its job. TSH might be normal if the problem is an autoimmune problem that really is coming from the thyroid stimulating antibodies. TSH might be normal. Free T and free T4 and serum, total serum T3 and T4 are measured. Free T4, of course, represents the unbound amount, will be elevated. T3 and T4 total will be elevated because the problem with hyperthyroidism is a sustained elevated T3 and T4. That's what the problem is all about. Okay, how are we going to take care of hyperthyroidism? 3 primary ways. Antithyroid drugs, RAI, radioactive iodine therapy, and subtotal thyroidectomy. Drugs. What drugs are we going to give? PTU and Tapazole. PTU and Tapazole block the conversion of T4 to T3. They take several weeks to work. We're also going to give beta blockers or calcium channel blocker to decrease the cardiac effects, specifically giving Inderal, a non-selective beta blocker, to decrease the excess stimulation of the sympathetic nervous system. Iodide or iodine. We use it with antithyroid drugs to get ready for a subtotal thyroidectomy or to treat the thyroid crisis. In large doses, it inhibits the synthesis of T3 and T4 and blocks the release in circulation. So we need a little bit of iodine to make T3 and T4, but iodide in large quantities inhibits the synthesis of T3 and T4 and thus helping the symptoms. We use it before surgery to decrease the vascularity of the thyroid gland, but its maximum effect is seen within 1 to 2 weeks. So we can use it rather quickly. It's not an effective long-term therapy. Some of the examples of the solution are SSKI, a saturated solution of potassium iodine, and Lugol's solution are the names of some of the products that we use. So again, it's iodine given in large quantities to decrease the circulation of T3 and T4 and to prepare the person for surgery. It's not for long-term use. Radioactive iodine therapy is the treatment of choice in all non-pregnant females. It damages and destroys the thyroid tissue. It is a different radioactive isotope. The RAI, the radioactive iodine uptake that we did to diagnose a goiter, is a different isotope than this isotope that we're using. We use it in, again, non-pregnant women. It takes 2 to 3 months to work. We treat it with, with the antithyroid drugs in the interval and the Inderal for the couple weeks, because it takes 2 to 3 months to work. So the antithyroid and the Inderal are on board ahead of time. We see a high incidence of hypothyroidism. We give this radioactive iodine to ablate or to kill or to stop the excess production of T3 and T4, and it often destroys the gland, and they have hypothyroidism, and then they need to take Synthroid for the rest of their life. Why do we do surgery? We do surgery when the person is unresponsive to drugs. So we've used the PTU, the Tapazole. We have done the radioactive iodine, and it's not working. We'll do surgery when there's a large goiter that's causing tracheal compression, when we think that there might be a malignancy, or where we have a candidate who is not eligible for radioactive iodine. Subtotal thyroidectomy is the preferred surgical procedure because you only remove a portion of the thyroid gland. 90% is removed to be effective. Let me tell you a couple more things about surgery. When we have somebody who's going in for surgery, we are concerned about bleeding. It's a very vascular organ. So, you have a post-surgical patient come out who's had a thyroidectomy. You are constantly assessing that dressing to see if it's bleeding. You are assessing the back of the neck because you don't want it dripping back on the bed and you not being able to see it. You are keeping all of your drains emptied and compressed. Drains come in, they're different shapes and sizes, but some are shaped like a grenade, has a little thing that you can open it and drain it on the bottom. But when you're done draining it, you have to compress it. You have to squeeze it down and put the lid back on, because that compression is what allows for the drain to work. Some are shaped like a donut, but the same thing. Keep it compressed. Keep it emptied. Support the patient's neck. Don't allow hyperextension of the neck. You are concerned for laryngeal edema. You are concerned that there is swelling. So you're going to look for early manifestations of swelling, laryngeal edema, which would be maybe the person sounds a little bit hoarse to you. Or the patient has a little bit difficulty speaking, or their voice is weak. You certainly don't want it to get to the point where there's a stridor. Because there is chance for laryngeal edema, you are going to have a trach set in O2 at the bedside. You'll have suction readily available. Other potential problems that you are looking for. You are looking for the pre-surgical calcium level. The parathyroid glands are located right on top, right near the thyroid gland, and because of that, they can be damaged and calcium levels could be down. So you're watching for pre and post calcium levels. Normal calcium level is 9 to 10.5 or 8.5 to 10, depends on what lab you're in. Signs and symptoms that you would be looking for would be tingling in the toes, the fingers, or the lips. You're looking for Chivestek. If you don't know that, that's when you tap on the patient's cheek and they have muscle twinging. You're looking for Trousseau sign when the hand dips down when you're doing blood pressure. I would expect for sure that if you do not know Chivestek and Trousseau, that you are on YouTube checking it out as soon as you're done listening to this. And again, comparing pre-surgical and post-surgical calcium levels is very important. What else are we going to do here? Nutritional therapy, very important. We need good high-calorie diet because otherwise their tissues are breaking down. We need high calories. We want low fiber because they have diarrhea. We want high protein. We want low caffeine. We want to make sure that they're not eating any spicy foods. We talked about this a little bit with the acute thyroid toxicosis. This is jumping back. We had said, just as a review, I'll do it here. So somebody with thyroid storm needs aggressive treatment. It is life-threatening. We need to give them medications to block the thyroid hormone. We need to manage fluid and electrolytes, maintain oxygenation and tissue perfusion, get them on a cardiac monitor, and watch for cardiac decompensation. We talked about in acute thyroid toxicosis and thyroid storm, you might need to tape the eyelids shut. Let's once again switch gears, and now we're talking about the parathyroid glands. The parathyroid glands are about the size of a grain of rice. There are anywhere from 2 to 4 of them, and they're located right behind the thyroid gland. And their job is to be responsible for the amount of calcium and phosphorus in the body. We remember that calcium is really important for electrical conduction, for the energy for our muscles, and it provides strength for our bones. Let's talk about normal thyroid function. Parathyroid function, excuse me. Normal parathyroid function controls how much calcium is in our blood and our bones. It is a negative feedback loop, but it does not involve the hypothalamus or the pituitary. When calcium levels are low, the parathyroid hormone releases PTH, parathyroid stimulating hormone. And PTH, what does it do? It stimulates bone resorption of calcium. That means we have stores of calcium in our long bones in the body. When PTH is high, we go in there and we dip in those long bones and we get out some calcium, and then we have circulating calcium. So when calcium is low, the parathyroid releases PTH, which stimulates bone resorption of calcium. It also increases renal reabsorption of calcium. Instead of spilling it into the urine, we start to hold on to calcium. And we activate the vitamin D to increase dietary reabsorption of calcium. So again, it is a negative feedback loop. PTH stimulates bone reabsorption of calcium, increased renal reabsorption of calcium, and it activates vitamin D to increase dietary absorption of calcium. Hyperparathyroidism. You can have primary, secondary, or tertiary. We are going to talk about secondary hyperparathyroidism. The most common cause is secondary hyperparathyroidism as a result of chronic renal failure. We know that in chronic renal failure, the kidney cannot hold on to the calcium, and we know that the kidney cannot excrete phosphorus. Phosphorus is high and calcium is low. We also know that the kidney cannot make vitamin D, and vitamin D is necessary for dietary reabsorption of calcium. So in hyperparathyroidism, we have an increased level of PTH. that increased level of PTH that we have is stimulating the bone the calcium reabsorption from the bone. It is stimulating the renal tubules to try to hold on to calcium. And it is trying to stimulate the kidney to make vitamin D to increase dietary absorption. Well, a secondary hyperparathyroidism comes from kidney disease. The kidney cannot hold on to calcium. The kidney cannot make the vitamin D to increase dietary absorption. So what happens is, the only thing that the parathyroid hormone is doing is stimulating bone reabsorption of calcium. But what happens is that eventually the calcium stores in our bones are completely depleted, and the person is susceptible has osteoporosis and is susceptible to fractures. And that's why that is a complication of renal failure. So when we have increased levels of PTH, we have an increase in serum calcium and a decrease in serum phosphorus. And when we have an increase in serum calcium greater than 10 or 10.5, whatever your lab is, we are going to see muscle weakness. We are going to see fractures, osteoporosis. We are going to see maybe cardiac arrhythmias. When we have a decrease in phosphorus, we're going to have muscle weakness. We talk here about hypercalcemia and hypophosphatemia. Remember that you can never look at a calcium level independently. It has an inverse relationship with phosphorus, yes, but you must also take a look at it with albumin. Calcium binds to the serum protein albumin, and that's how it moves, that's how it circulates, that's how it gets from one spot to another. So if albumin is low, it will look like calcium is low. So I just wanted to make that point. So there you have the clinical manifestations. Calcium greater than 10. We are looking for, in diagnostic studies, an elevated calcium. We are looking for a low phosphate and phosphate less than 3. It should have an inverse relationship. Depends on your lab again, but most labs will agree that 2.5 to 4.5 is a good phosphorus level. If the patient is a renal player, a dialysis patient, 3.5 to 5.5 is acceptable. Other diagnostic tests, elevated PTH levels. We're looking at renal function, of course. DEXA scan, taking a look at the density of the bones, and of course x-rays. An increase of calcium in the urine would indicate that the person is at risk for stones or renal calculi. So when I say an increased risk or increased calcium in the urine, you should immediately be thinking, I'm going to increase fluid intake for this person. But that might be a concern for one of my renal patients because fluid volume overload is a problem for them. So keep that in mind. Collaborative care. What are we going to do? Well, we're going to try and treat the signs and symptoms. We are going to increase fluid if that's a possibility for my renal patient. We are going to have a moderate amount of calcium intake. We might provide a calcium supplement. We might give them a drug called Sensipar because that will decrease PTH levels. We can give them another drug called mithracin, M-I-T-H-R-A-C-I-N, because that's an anti-hypercalcemic. We might give them the diuretic Lasix to spill calcium. But again, it depends on whether it's a primary, secondary, or tertiary cause of hyperparathyroidism. Most frequently, it is chronic renal failure and secondary. We might give them a biphosphonate, something like Fosamax, to inhibit bone reabsorption of calcium. But ultimately, we monitor for signs and symptoms of hypocalcemia. They might need surgery. One last word before we do disorders of the adrenal cortex about a surgical procedure, surgical treatment or surgical therapy. If we need rapid reduction of calcium, we can do surgery. They do it by endoscopy. They can do partial or complete removal of the parathyroid glands, and then they do something they call autotransplantation. So they take a parathyroid gland and they transplant it in the forearm, and that is the one parathyroid gland transplanted into the forearm allows normal amounts of PTH to be present. If the autotransplantation fails, like it doesn't work, then the person has to take calcium for life. Now, disorders of the adrenal cortex. All right, now we're talking, switching gears a little bit. We're talking about disorders of the adrenal cortex. Let's think about the adrenal cortex and what are the substances, what are the hormones that are secreted from the adrenal cortex. They release cortisol, aldosterone, and androgens. We can say that they release glucocorticoids, and the glucocorticoid is cortisol, mineralocorticoid, and that is aldosterone, and then androgens are some of the sex hormones. Let's talk about the glucocorticoid steroid, or glucocorticoid and cortisol. What do? It's one of the most important regulators of blood glucose. It stimulates hepatic gluconeogenesis, which you remember is the conversion of amino acids to glucose. It inhibits protein synthesis, and it inhibits the inflammatory response. So, cortisol, a glucocorticoid, is responsible for blood sugar regulation because of the hepatic stimulation of gluconeogenesis, the conversion of amino acids to glucose. It inhibits protein synthesis, and it inhibits the inflammatory response. Aldosterone, the mineralocorticoid, is stimulated by angiotensin II. It's stimulated when there is hyponatremia or hyperkalemia. It's inhibited by an increase in BNP and hypokalemia. So, what does aldosterone do? It holds on to sodium and water. It is responsible for sodium and potassium balance. We remember that typically sodium and potassium run opposite of each other. Then the last thing, the androgens, that's some of the growth and development in men and women. Okay, like the thyroid, we have the HPA, hypothalamus pituitary adrenal gland axis. The hypothalamus releases CRH, sends a message to the pituitary. The pituitary releases ACTH, and then the adrenal gland releases cortisol, aldosterone, and androgens. When those levels are low, a message is sent back to the hypothalamus that sends a message to the pituitary, which sends a message back to the adrenal gland. When the levels are high or in sufficient quantities, there's no message that goes back because there's nothing that needs to be done. So what is Cushing's disease? Cushing's disease is an excess in corticosteroid and mineralocorticoids. It is an excess of the hormones of the adrenal cortex. The most common cause is that we gave you too much corticosteroid, but you could have a tumor on your pituitary gland or your adrenal gland. So it's a spectrum of clinical manifestations that are caused mostly because of the excess in corticosteroids followed by the mineralocorticoids. So let's take a look at what those excesses are. An excess of the corticosteroids and some of the clinical manifestations, some of the signs and symptoms. We're going to have what they call centripetal obesity or truncal obesity. That typical moon face that you see when people are chronic steroid users. A buffalo hump, which is like a big fat pad on the back of the neck. Weight gain, transient weight gain from the sodium and water retention. These people also have like a pendulous belly, a pendulous gut, and it has purple striae on it. Let's look at the clinical manifestations as they relate to the hormones. So primarily increase in cortisol. What's that going to do? Well, when I have an increase in cortisol, I'm going to increase gluconeogenesis, which is going to give me hyperglycemia. That's why when we give people cortisol or cortisone in the hospital, their blood sugars go off the chain. So increase in gluconeogenesis causes hyperglycemia. It causes insulin resistance. And the liver increases the gluconeogenesis, which is what causes the hyperglycemia. Increased cortisol will also give me muscle wasting because I have inhibited protein synthesis, so I get muscle wasting. With the inhibited protein synthesis, I also have a risk for osteoporosis and pathologic fractures. I have a suppression of the inflammatory response, so I will have delayed wound healing and thin skin and easy bruising. When I have an increase in the mineralocorticoid aldosterone, I hold on to sodium and water. And when I hold on to sodium and water, I have potassium loss. But when I hold on to sodium and water, I get a secondary hypertension. And if it goes on too long, I can have cardiac-related symptoms like heart failure. And then, of course, the increase in the androgens, you know, all kinds of fertility issues, but acne and women growing facial hair. Okay. So let's look at, as a result of the increase in cortisol, this is really important. It gives you the signs and symptoms of Cushing's disease, but it also helps you to understand some of the inflammatory process, because when you have the inflammatory process, we have increased levels of cortisol because we have that fight or flight reaction. It also helps you to understand what you're doing to a person when you give them cortisol or prednisone or dexamethasone, which we give all those anti-inflammatories, steroidal anti-inflammatories. So the hyperglycemia, we have an insulin resistance. We have an increase in gluconeogenesis by the liver and an increase in blood sugar. The protein wasting, we have the catabolic effects of cortisol, which lead to weakness in the extremities, loss of protein in the bones, which is osteoporosis and back pain. We have a loss of collagen, the wound healing, insomnia, psychosis, because a steroid psychosis. We have the purplish red striae on the abdomen, breast, and buttocks. How are we going to diagnose it? Well, we are going to diagnose it with plasma cortisol levels as the primary thing. And then we're going to do a 24-hour urine for free cortisol. Increased levels of free cortisol indicate that we have Cushing's disease. Cortisol levels should be, you don't need to memorize it, between 80 and 120, so anything above that would be indicative of Cushing's. We can get false positives for increased cortisol levels with certain drugs that we use, with certain drugs like Dilantin or rifampin, but it can also be elevated with extreme depression or stress, because cortisol levels are increased with stress, so during times of extreme stress, or alcoholism. We also want to do a CT or an MRI of the pituitary and adrenal glands to make sure that there's no secreting tumors on there. Plasma ACTH, which is released from the pituitary, may be high or low depending on the cause. So high ACTH would equal a problem with Cushing's disease. If you have a secreting tumor, if you have a secreting tumor on the pituitary gland, they remove the pituitary and then the signs and symptoms will resolve themselves. Even the changes in appearance that happen, if they take that tumor away, those changes, the pendulous stomach and the buffalo hump, the moon face, all of those signs and symptoms will, or appearance characteristics, will resolve themselves. And we'll talk about pituitary tumor removal in a little bit. Collaborative care. What is the goal? The primary goal is to normalize hormone secretion. So if it's because we've been giving too much steroid, then we got to stop it. We got to reduce the dose, or we have to wean it down, so we might use alternating days. If it's a pituitary adenoma, we got to get it out of there. We can do it with a hypophysectomy, or we can do it with radiation, a stereotactic radiation, gamma knife surgery. Adrenal tumors or hyperplasia get an adrenalectomy. Drug therapy is indicated when surgery is contraindicated or as adjuncts to surgery. So when we're going to use some drugs to decrease the amount when necessary, as getting ready for surgery or when surgery is not enough. Addison's disease. Addison's disease is too little, not enough of the glucocorticoids, mineralocorticoids, and androgens. So we don't have enough cortisol, we don't have enough mineralocorticoid and aldosterone or the androgens. It's most commonly an autoimmune problem that attacks the adrenal gland. It's a slow and insidious onset, and they don't see it coming. The primary features are a progressive weakness, fatigue, weight loss, anorexia. This hyperpigmentation over the skin creases and the joints. When they have orthostatic hypotension, because they don't have enough. A lot of the problems are related to their blood pressure. Orthostatic hypotension, if we don't have aldosterone, we're not holding on to sodium and water, so we're spilling sodium and water. So we're going to have a hyponatremia, hyperkalemia, because we spill sodium and water, we hold on to potassium. If I'm not holding on to sodium and water, I'm at risk for orthostatic hypotension. Nausea, vomiting, diarrhea are a concern. Irritability and depression. When we're treating these people, we're really looking to replace cortisol and balance sodium and potassium. That's the main goal. So let me say that again. The main goal for treating people with Addison's disease is to replace the cortisol and balance sodium and potassium. The clinical manifestations are related to the decrease in cortisol, so decrease in gluconeogenesis causing hypoglycemia, and the decrease in aldosterone causing sodium and water loss, potassium retention, and hypotension. Here we talked about these: orthostatic hypotension, hyponatremia, hyperkalemia, nausea, vomiting, diarrhea as signs and symptoms. Okay, Addison's disease complication, a complication called Addisonian crisis. What is it? It's a life-threatening condition caused by an insufficient amount of adrenocorticoid hormones. It is a sharp or sudden decrease in these hormones, as in when we instantly stop cortisone or prednisone, the steroids. That's why we need to taper them. It can be triggered by stress or infection, surgery or trauma. What's it look like? Well, it is a severe decrease in hormones. So when I have a decrease in cortisol, I am going to have the main problem be hypoglycemia. When I have a decrease in aldosterone, I am going to see a decrease in sodium and water, and I'm going to see an increase in potassium. Because my volume will be significantly down, I will have hypotension, tachycardia, and dehydration. We said it's a life-threatening emergency. So that life-threatening emergency, that hypotension, severe hypotension, can lead to shock and eventually circulatory collapse. So these are people in Addison's crisis who would need to have fluid and maybe vasopressors, because we can't have shock and we can't have circulatory collapse. There are some GI manifestations that could be severe vomiting, diarrhea, and abdominal pain, further decreasing their volume deficit. Let's spend a little time talking about how we diagnose Addison's disease. Well, we diagnose it as subnormal levels of cortisol. I have here, levels fail to rise over basal levels with ACTH stimulation test. Let's talk about an ACTH stimulation test. What is it? Well, we get a baseline. We draw a baseline cortisol level. Then we administer ACTH. If I administer ACTH, you would think that that stimulates the adrenal gland to produce the hormones, and so hormone levels should increase. If the hormone levels do not increase, we say they have adrenal disease. So, draw a baseline cortisol, administer the ACTH, which is normally released from the pituitary and stimulates the adrenal gland to make the hormones. So I draw a baseline, give ACTH. If the levels go up, that's okay. If the levels do not go up, we diagnose that as Addison's disease. What am I going to find in terms of other diagnostic studies? Well, I'm going to find hyperkalemia, hypochloremia, hyponatremia, hypoglycemia. We've talked about all of those. Low urine cortisol levels. Of course, everything's going to be low. They're the primary. Primarily, I want you to know hyperkalemia, hyponatremia, hypoglycemia. What are we going to do about it? Well, we're going to treat it with cortisone. It's most commonly used for hydrocortisone for replacement therapy. It's important to teach your patient who's sent home on cortisone not to stop taking it. We know with every stressful situation that if they are in a period of stress, we might need to make adjustments to the medicine, to the hydrocortisone, to prevent Addison's crisis. We remember, just as a review, we talked about it a couple minutes ago, with Addison's crisis, we're doing shock management, so large volumes of IV fluid, followed by vasopressors if necessary, until we're sure that there's adequate tissue perfusion. I would know that there's adequate tissue perfusion based on a pulse ox, based on hourly urine outputs. It may be, in Addison's crisis, it may be an unrealistic expectation for blood pressure to be normal. It doesn't need to be normal. It just needs to be in adequate amount to maintain perfusion. And in Addison's crisis, of course, high doses of hydrocortisone replacement. Oh, there it is. I didn't see that. So that's what we just talked about. What are we going to do? Addison's disease. Frequent assessments, vital signs are going to be critical. We're watching for those fluid and electrolyte imbalances. In the first 24 hours, we might be taking signs Q1 hour. Daily weights and corticosteroid therapy diligently administered on time. We are teaching the patient signs and symptoms of corticosteroid excess and deficiencies, and they are to report that to their doctor. They should be wearing a MedAlert bracelet. We are going to make sure that we have written material, as well as many times we have written, audio, visual, as well as our individual teaching. When we are using drugs like aspirin, potassium, depleting diuretics, dilantin, phenobarb, antibiotics, insulin, we got to be careful. Suffice it to say, anything that is going to adjust sodium, anything that is going to adjust potassium or blood sugar is a risky drug when we're dealing with Addison's disease. Patients need to learn how to take their own blood pressure because they're managing this at home, and we have to have them carrying, because most times they will, with Addison's disease, be taking PO medication. They'll have an emergency kit with IM hydrocortisone in there, and we've got to teach them how to give an IM injection. Here's my summary sheet, the takeaway. With Cushing's, it's an elevation of cortisol and aldosterone. With the elevations in cortisol, we have hyperglycemia, poor wound healing, protein catabolism, muscle wasting. With the increase in aldosterone, we have sodium and water retention, potassium loss, arrhythmias are certainly, dysrhythmia is certainly a problem, hypertension is a problem. With Addison's disease, we have a decreased level of cortisol, so we have hypoglycemia. We have a decrease in aldosterone, so we have lost sodium and water, and we're retaining potassium, again with a dysrhythmia concern, but we have tissue perfusion and circulatory collapse as a potential devastating result. In one, we are giving cortisol and managing blood pressure in Addison's disease. Just a word about transsphenoidal hypophysectomy. When we have a pituitary tumor, a secreting pituitary tumor of some sort, we might use this transsphenoidal approach. So they make an incision along the upper lip, inside the mouth, between your lip and your gums. And they are able to enter into your brain through your nose and your sinuses. I'm sorry. They go up through your mouth, under your face, through the back of your nose, and they're able to, and then through your nose and these incisions, they're able to go in and clip out the pituitary. You can see the scissors in there in the green pituitary gland. What's important for you to know? Well, when you're done, you are going to keep the head of the bed. After the surgery comes back, the patient will have their nose and sinuses will be packed. Their face is bruised. They look terrible. The head of the bed is elevated 30 degrees at all times. We are watching for nasal drainage, and we're checking for glucose to make sure that we're looking for those concentric rings on a gauze pad to make sure that they're not leaking cerebrospinal fluid. Mouth care every 4 hours. No toothbrushes, but you have to have good mouth care because we don't want them to get infected. Lots of times we use a chlorhexidine mouthwash, a special mouthwash. We are looking for signs and symptoms of diabetes insipidus related to pressure on the posterior pituitary and the lack of antidiuretic hormone leading to diabetes insipidus. So we're going to monitor urine output by the hour, and will help us determine about diabetes insipidus. Let me see if there's anything else I want to tell you. Okay, no, I don't think so. One last area to talk about today, and that's some disorders of the pituitary. You already talked about this a little bit with Professor Roy, but we're going to do it again just to solidify the concepts. So the anterior pituitary produces ADH, antidiuretic hormone. Antidiuretic hormone is produced in the anterior pituitary and stored in the posterior pituitary. Its major job is to hold on to water. It is important to note it does not increase renal retention of sodium. So its job, its major function, is to regulate fluid by stimulating the renal tubules to hold on to water, making more concentrated urine. Let me say that again. It does not affect renal retention of sodium. It only asks the renal tubules to hold on to water, which creates more concentrated urine. ADH is also called vasopressin, and you'll recognize that as a pressor. So it is a potent vasoconstrictor. Secretion of ADH is stimulated when we have an increase in plasma osmolality, or we can say ADH is released when the blood is thick, when our blood volume is down, we increase ADH. So if my blood is thick or my volume is down, I release ADH, and ADH is going to hold on to water. Just like when cerebral perfusion is down, when my brain is not getting enough oxygen, it stimulates the release of ADH and asks the renal tubule to hold on to water. Well, there are two syndromes, disorders of ADH. The syndrome of inappropriate antidiuretic hormone, which means we have an overproduction of ADH. So syndrome of inappropriate antidiuretic hormone, that means that the posterior anterior pituitary is going crazy and there's tons and tons of ADH on board. If there's tons and tons of ADH on board, I'm holding on to lots and lots of water. When I'm holding on to lots and lots of water, you should be saying to yourself, wow, that's going to be a real problem with sodium. There's going to be a dilutional overhydration, a dilutional hyponatremia. You should also be saying to yourself, extra fluid volume is going to really be working that cardiovascular system hard. Then we have the diabetes insipidus, which is not enough ADH. And if we don't have enough ADH, we're not holding on to sodium and water, so we would have a volume deficit problem and lots of urine. So let's look at SIADH, or an increase in ADH, antidiuretic hormone. Increased antidiuretic hormone means increased water reabsorption in the renal tubules. It means increased intravascular fluid volume. When I have increased intravascular fluid volume, I have dilutional hyponatremia. I have the right amount of salt in there. It's just that I have too much water, so it looks like my sodium is low. And I have a decrease in serum osmolality. Lots and lots of water, but it's not thick. It's very thin, my serum osmolality. And I would expect my urine osmolality to be up. I would expect a very concentrated urine. What are we going to teach these people with chronic SIADH? Fluid restrictions. Use ice chips and hard candy if they're thirsty and their mouth is dry. Diuretics are very, very important. And we are talking about supplementing sodium and potassium if they're taking diuretics. And teaching signs and symptoms of sodium and potassium imbalance. When you are taking a test, just a word to the wise. You see that last line down there? It says signs and symptoms of sodium and potassium imbalance. I'd be pretty sure that on a test item, you would not see that listed like that. I'm pretty sure I would tell you something like dry mucous membranes and irritability. And you would be saying, oh, that must be a decreased serum sodium. So make sure that you review what signs and symptoms of sodium increase and decrease, potassium increase and decrease are. Diabetes insipidus, or not enough ADH. Decreased ADH. So there's decrease in water reabsorption in the renal tubules. So we have decreased intravascular fluid volume, which means that we have thick blood with an excessive amount of urine, with a very dilute urine. I'm also thinking about blood pressure when I'm thinking about having a decreased intravascular volume and thinking that orthostatic hypotension might be a problem. Diabetes insipidus is a diabetes insipidus can be a cause, can come from, sorry to struggle over my words, can come from a closed head injury. Diabetes insipidus can come from brain tumor or brain surgery like the hypophysectomy. What's discharge teaching for these people? We got to give them DDAVP, which can come orally IV or as a nasal spray. And that is the replacement of the ADH. It causes nasal irritation. It can cause nausea. We're watching their weight every day. These people need to carry a water bottle with them. And again, there we have signs and symptoms of dehydration and electrolyte imbalance.